Hi there, I'm Dan, I'm a junior doctor, and if you're new here, I am currently taking a little bit of a break from clinical medicine in the NHS. I've been reflecting over my career, which has now been 5 years. In that time, I've worked in many different specialties across many different settings. Medicine has given me some unbelievable experiences, and there have been some really big challenges that I've had to overcome along the way. In this series of videos, I want to share some of those experiences, go back, relive them, and tell you how I felt and what I learned from them. Today we're talking about my second year as a doctor in my F2 year. Hi there, I'm Dan, I'm a junior doctor, I'm from London. In this series we're going back through my experiences as a junior doctor. If you've missed the first video, then go check that out. That's on my F1 year, my very first year as a junior doctor. After my F1, that was at the Royal Derby Hospital. With a bit more confidence in my abilities, I headed north, and that was to Mansfield, or Kingsmill. My first job at Kingsmill was a paediatric job, and in general it was an awesome job. I now actually really enjoy paediatrics and worked in it since, but at the time I had very little paediatric experience and actually was quite apprehensive about the job. I was very aware that, being kids, you had maybe even more responsibility than you do as an adult doctor, but I also found it difficult to pitch communication with kids. I didn't really understand the difference between a 6-year-old and a 3-year-old, and in general just being around them I found quite nerve-wracking. This all improved with experience, and very quickly you get the hang of it. Since then I've done a lot of paediatric work. When I was at Kingsmill I was seeing everything, and that was really good, to be honest. We were looking after the neonates in the NICU. We didn't have really premature babies, but I still got to see lots of patients who required ventilatory support because their lungs were quite immature and they weren't breathing properly. I then also got to see lots of normal babies when they were born and taken to the postnatal wards. Did lots of newborn baby checks, which after a while can get quite similar. I saw lots of different patients on the acute ward, which was from anything from a newborn, with neonatal jaundice or feeding problems, all the way up to 18 with sort of new diabetes or mental health problems. As a result, it was quite a big team because we were covering all of the paediatric services. The consultants were brilliant. They were really understanding that paediatrics was a new job for me, learnt loads from them. And the other thing that I liked was that they were all general paediatricians, but they had a specialist interest. So there'd be one consultant that had an interest in renal, for example, and they'd see all the HSP patients or all the acute kidney injuries. And then there was another consultant who had an interest in cardiology, and they'd review all the paediatric echoes. So what this means is that as a team, you could keep everything within the team. One of the biggest things that you hate doing as an SHO is trying to get an opinion sometimes, where you have to go through switchboard or call someone at home, and this just sort of eliminated most of that. There were still times when we still had to refer out to different teams, but I really liked the way that actually most of the stuff could be done within the team, and that just made things more efficient, made our lives easier. So like I said, I got really good general exposure to paediatric patients. There was lots of breathing issues, lots of infections, so that's pretty typical, things like CF and DKA. But one of the highlights of the job for me was actually going to the labour ward and being there when babies were being born. So if you were an F2, a GP, or one of the paediatric SHOs, you held the labour ward bleep. And essentially you would get bleeped if there was a baby that they were anticipating may have respiratory distress or any other kind of distress as they were born. So there's certain things that you can sort of use to predict this kind of thing. So you're more likely to have it if you're a premature baby, or sometimes the obstetricians are unhappy with the CTG, the monitoring that we use in labour to keep an eye on the baby. And so you would get bleeped if things started to go south during a labour, or there was an emergency C-section, or any of these signs sort of pointed towards the fact that the baby may or may not be in distress. I was part of that team. If anyone's ever been in a delivery room, but you may have seen that there's a group of doctors that stand in the corner near the resuscitaire, which is the sort of small baby cot that we use to resuscitate neonates. And they're essentially the paediatric team. So they're waiting for the baby to come out. And normally, if there's concerns, the baby will be handed over to the paediatricians. They'll have a look, maybe do some resuscitation, and then hand the baby back to mum as soon as that's appropriate. So this all sounds quite scary, but actually the good news for paediatricians is that babies are designed to deal with a degree of hypoxia that often occurs during the process of human birth. So that means that actually just doing a few simple steps, you can get a really good outcome from resuscitation. So a baby may come out looking flat or pretty rubbish, and if you just do things like dry the baby, stimulate them slightly, and if that's not worked, then give a few rescue breaths, often those 3 things will sort out most of the issues. Now, there are things that go wrong, there are exceptions to that, and those sort of things that go wrong and those exceptions increase dramatically with the level of prematurity. So we weren't dealing with very premature babies because we were quite a small centre, but as a result, we had some really good resuscitations. There were still some babies that came out quite sick, but often we had an idea that that was going to happen, and often at that point the registrar or the consultant even would be there and they'd be giving the resuscitation. The things that we looked at were things like anomaly scans to see if there were any abnormalities, maybe some cardiac abnormalities, and the other things were, was the baby premature or was the mother diabetic, things like that. But this is when I realised that I really started to like Paeds. In adults, if you're at the point where you're having to breathe for the patient, you know, the patient's really sick and they're not going to just bounce back. And yes, equally, if you have a child that's like that, they're also not just going to bounce back. But in general, when children get sick, they respond much better to treatment. For example, in asthma, kids can just have terrible asthma. You give some steroids, you give some bronchodilators, and you can be discharging them when they were coming in looking really unwell. That just doesn't really happen in adults. They'd normally be admitted. So it's really satisfying seeing your treatment actually work. In general, I loved those 4 months, really enjoyed going to work. And since then I've done lots of paediatrics, and I put that down to having such a good experience at Mansfield. Overall, that was probably an 8 out of 10 I'd rate that job, and yeah, really enjoyed it. So the next job was slightly different. It was geriatrics and acute medicine. So I went from one end of the spectrum to the next. And I think this is a really good example of just how varied being a doctor is. You may have to be seeing a patient in A&E that is 4 years old, or you may have to see one that's 84 years old. And I think that variation is really rewarding and is overwhelming at first, but after a couple of years of experience, you're able to sort of figure out who's a sick patient and who's not. However, unfortunately, this was probably one of my worst jobs of my foundation years. So we were a geriatric ward, and we were mainly dealing with patients that were over the age of 75, or any patients that were younger with what we call extreme frailty. Geriatrics is not dissimilar to paediatrics in that it's quite satisfying. There are a couple of simple things that you can often do, and often those can actually resolve fairly significant symptoms, like make sure the bowels are opening, make sure the patient's orientated, make sure they're hydrated, and try and get a resolution of the problem. However, if those things don't start to work, then you may actually be dealing with a sick patient. And obviously, due to geriatric patients' frailty, when they become unwell, they become very unwell and have less physiological reserve to sort of overcome a big insult. So now you're looking at a patient that may actually be quite sick. And obviously, with the fact that they're very frail, we then have to have lots of discussions around what is the appropriate level of treatment. This is where geriatrics becomes much more complicated and requires very good communication and empathy. And then we also have to make a sort of team decision and try and figure out a bespoke care plan for a patient, and also acknowledging that not all patients want to have every treatment. And this can be really tricky. Unfortunately, capacity becomes quite a big topic when you get into the geriatric sort of cohort. Some patients may have already had dementia, and so you don't actually know what their beliefs are around certain things like end-of-life care. Some patients, often being that unwell, will become delirious, and so you can't ask them exactly what they want or what they would like. So capacity is the ability to make a specific decision at a certain time and then be able to communicate it. Patients may not have a next of kin, patients may not have much family. So these are the patients that are quite complicated and require quite a lot of thought, team discussion, and you're trying to balance what is appropriate whilst also being an advocate for your patient. There's lots of ethics involved in this part of the job, lots of communication skills, and actually I find this part quite interesting, quite rewarding. So that's the sort of complexity of the patients that we were dealing with. And unfortunately, we had a very high workload. We were quite short of staff, and often we had new registrars that were rotating lots. There was no sort of continuity with the team. I was a rotating doctor, so I was only there for 4 months, but moving into the ward, I could tell that it wasn't a team that was working very well together. Despite that, I had some really interesting patients. Like I said, a lot of our patients were approaching the end of their life, and there were a couple of patients that really still to this day stand out to me. I do enjoy that aspect of the job. I had this when I went onto my picky job, which is the job we're going to be talking about next. When you're working with someone as they approach their end of their life, you know, for example, I may have had an 80-year-old that has got 80 years of stories, 80 years of experiences, relationships. They may have worked in the army, they may have been involved in the war, you know, done amazing things, and I am there now at the end of their life. I'm the one that's advocating for them. I'm the one that's trying to keep them pain-free. And that's a really quite unique experience. And it just, when you're thinking about that, there's very few things that actually you feel like a better use of your time. It's very satisfying, and very trivial things like making sure they aren't thirsty or making sure their water is topped up. Those things become really important, and I love that. I really enjoy that. However, despite those moments that were really quite rewarding and just really nice human moments, the job itself was quite stressful. I found the workload difficult. The on-calls actually were even worse. So yeah, it was a really stressful job. I learned a lot, I learned how to prioritise, but yeah, enjoyed the specialty, didn't massively enjoy the ward, and probably would give that a 3 out of 10. Wasn't the best job in the world, but learned a lot. So the next job I had was my public health job. Now this is a pretty odd job to have as a foundation doctor, not typical, but I would highly recommend that if you are looking at your foundation years and there is a public health opportunity, then go for it. It was awesome. So I moved away from Mansfield and back to Nottingham, and this was much more local for me. And this was really novel because I, for the first time in my life, had an office job. I was working 9 to 5, I often finished earlier, I could work from home, I didn't see any patients, I was given a laptop, and actually I'd never had an office job in my whole life. You know, the novelty did wear off. I was in something called health protection, so there's lots of different aspects to public health. Our job was looking mainly at infections and things to prevent infections spreading, but rather than looking at an individual, we were looking at the population as a whole. So it was more about vaccination, managing outbreaks, and reporting notifiable diseases. Remember, this was before COVID, so it was before public health became sort of part of the public or collective consciousness. So probably the highlight of the 4 months for me was working on a measles outbreak. And this was in a travelling community with a much higher proportion of the community being unvaccinated than in the normal population. I ended up going to meet the patient. It was the first patient I have ever seen, the only patient I've ever seen with measles, and got to examine the patient, take a very thorough history and figure out exactly where he'd been over the previous 2 weeks. Took all that information back to the office and we sort of digested it as a team. The problem with measles is similar to COVID, you become infectious before you develop symptoms. So the rash may come on day 4 or day 5, but you've been infectious that whole time. That presents an issue of spread for the public health doctors. So the most typical symptoms are things like measles rash, white spots within your mouth called Koplik spots, general sort of malaise, feeling unwell and having a fever. However, measles itself can cause things like pneumonias and sepsis, especially in age groups like infants and neonates, as well as the elderly. So unfortunately for us, this chap had been all over the country. He'd literally taken 2 ferries, we had to speak to both ferry companies, and he'd been everywhere. So contact tracing was quite a lot of work, and we had to figure out exactly who he'd seen, when he'd seen them, whether he'd been infectious, and then if they were vaccinated. And then if they weren't, we had to figure out, do we need to get in contact with them? Have they developed any symptoms? And you sort of get the idea that we were trying to piece together exactly where he'd been and where the infection chain had spread. So some of his family did go on to have measles and have symptoms. Luckily for us, we were able to get onto the site and actually vaccinate a number of patients that actually weren't vaccinated previously. And this prevented further spread. So this is a fairly classic case of measles. In the UK generally, we have a fairly good vaccination rate when it comes to measles, mumps and rubella. And as a result, we only see measles in certain pockets where the vaccination status in that sort of group are much lower, Irish travellers being one of them. What I really enjoyed about the outbreak was that we did have to navigate the sort of cultural differences, the different understandings of health beliefs, and make a very conscious effort to be aware of those differences. As a result, sometimes these populations can be more challenging to treat, but actually we got a really good outcome and managed to get a really good uptake of the vaccine on the site. Actually, I remember the patient being extremely grateful for the fact that we got his kids vaccinated, because I remember him saying how unwell he felt and that he didn't want that for his children. So overall, it was a really good outbreak to be part of, to be managing, and I actually ended up presenting it at a conference in Nottingham. Other things I did over the 4 months were things like working on a mumps outbreak, which was very prevalent amongst the students of Nottingham and Trent. I also did some work on IGAS, or Invasive Group A strep, which is also prevalent in certain populations like the homeless. And actually, really interestingly, when I was on my taster days, I was doing them in ITU, and the very first patient I reviewed was an IGAS patient, and they were septic. And just going from the public health office and dealing with it from a population basis, and then seeing a patient who actually had one of the diseases that I was taking calls about, that was just a really interesting thing to see, and it sort of showed the importance of both the sort of clinical medicine as well as the population. So like I said, I would recommend public health to anybody. It was absolutely awesome. Yeah, overall would rate it probably an 8, 8.5, 9 out of 10. So yeah, and just like that was my foundation years over. It definitely didn't feel that quick at the time. There were definitely some highs and lows, and I hope I've given you a bit of an insight into some of the challenges as well as some of the really good experiences that I've had. So in the next video, we'll be talking about the next job that I had, and that was on the Paediatric Intensive Care Unit at St George's, or PICU. We're looking after critically unwell children, so make sure you don't miss that. Subscribe to the channel, and I'll see you in the next video. Cheers.